Hi, I'm Dante Pieramici, and I'm a vitreoretinal specialist at California Retina Consultants. I've been involved in clinical research for various retinal diseases for the last 30 years. And I'm excited to see drug delivery now moving into a more extended drug delivery. We've seen the port delivery system and the effect that it can have on diabetic disease, stabilizing DME, stabilizing diabetic retinopathy over the long haul for many years. And now we have some potential non-operative options. And one of those may be EYP-1901 drug delivery device. And we've now have some exciting news that both the COMO and CAPRI, which were phase 3 clinical trials, looking at this drug delivery device, the 2.7 milligram dose, compared to standard of care aflibercept injections in patients with center-involved diabetic macular edema. And so we look forward to, now that the studies are fully enrolled, somewhere about a year from now, reading out these trials at the 1 year outcome to see if the insert re-injected every 6 months is non-inferior when it comes to visual acuity and anatomical results, but with far less treatment burden over the course of a year or two.
So the COMO and CAPRI trials enrolled more than 480 patients across both trials in just 5 months. So that's ahead of schedule. What does that enrollment moving fast like that tell you about the retina community and patients viewing the current DME treatment burden?
Well, I think it first of all tells you that there's a pretty good burden still out there. Despite great results with anti-VEGF injections, many of these patients require frequent injections. And many of the patients, unfortunately, don't get those frequent injections in the real world. And even despite frequent injections, if we look at the clinical trial results, many of the patients aren't completely dry despite frequent intravitreal anti-VEGF injections. So there's a burden out there. There's a burden of the treatment, but there's also an unmet need in drying out patients with diabetic macular edema. And diabetic patients are even more difficult than neovascular AMD patients. They're much more likely to miss follow-ups. They have other medical problems going on. They're younger working age people. And to have a treatment that's long lasting or longer lasting, that's going to be less burdensome on them, I think is going to improve the real world outcome. So I think there's a big demand for this. I think the trials also have recruited well for a number of other reasons. I think that, first of all, the COMO and CAPRI trial, they took both naive and previously treated patients. So they have a broad spectrum of patients, which I think is going to be good because it'll be more like the real world at the end of the day. But that also made recruitment a little bit easier. In addition, the investigators in the COMO and CAPRI, many of them are the same ones who are Lugano and Lucia investigators. So they already had their teams ready to go, and they were plugged in. So they could get the diabetic macular edema trials going pretty quickly. I think too, these trials, they're providing for patients really an option to be treated in either arm. So patients don't have to worry that they're going to get either treatment or observation. So they got standard of care treatment that was provided by the company as well. So I think there's just a lot of reasons and a lot of excitement in trying to find more durable, efficacious, and safe. And I think the other final thing, really, when it comes to why did they recruit so quickly, is I think that we had seen in neovascular AMD patients, that the drug was very safe, and we weren't seeing a safety signal. Patients tolerate the injections very well, just like a typical intravitreal injection. And so, offering a patient either what you get standard of care or perhaps something that may last longer is an easier sell. So I think that doesn't surprise me that they recruited so well.
So these are non-inferiority trials against on-label 2 milligram aflibercept with Duravyu redosed every 6 months and a blended BCVA endpoint at 52 and 56 weeks. Why is that the right design to answer the question DME clinicians care about?
Well, I think that first of all, I think it's the right trial because it's a non-inferior when it comes to visual acuity change over this treatment period, but it's really a superiority trial when it comes to the number of treatments that are going to be necessary. So what we're looking for is to have far fewer treatments to have a higher percentage of patients going without needing a treatment and during the 6-month treatment interval. So I think that's really what we're looking for. And I think it's also an ethical design for patients. We're providing patients either standard of care or this. We're not providing them basically observation, which I really don't feel is right when you have a good therapy. In addition, I think the study was designed with retreatment criteria that's reasonable and safe for patients. And the blended endpoint has become fairly typical. We saw this in trials for 8 milligram aflibercept as well as the faricimab trials using this blended point. And I think that that's helpful because you're making a conclusion based on more than just one time point. It's 2 time points. And it also investigates different time points from the last treatment. So, 52 weeks will be 4 weeks from the last treatment in both groups, and then 56 weeks will be 8 weeks from the last treatment. So we'll gain a little more information about how things are changing over that little interval. So the blended endpoint, I think, is reasonable in this trial as well.